Hi, my name is Diane Teresa Soliano, and I'm here to report about the COPD and the CRPD, or commonly known as chronic obstructive pulmonary disease and chronic restrictive pulmonary disease. Now, here we have fourth. Now, why fourth? Do you all know that COPD is currently the fourth leading cause of death in the world? It continues to increase in the adult population, and additional increase in prevalence or mortality are predicted in the coming decades. So, COPD is a preventable and treatable disease with some significant extra pulmonary effects that may contribute to the severity in patient. Its pulmonary component is characterized by airflow limitation. So the airflow limitation is usually progressive and associated with an abnormal inflammatory response of the lung to noxious particles and gases. Now we have here the chronic airflow limitation that characterizes COPD is caused by a mixture of parenchymal alveolar disease or emphysema and small airway disease such as obstructive bronchiolitis. So obstructive bronchiolitis is oftenly paired with COPD. And now we have here smoking. So, cigarette smoking is the most common risk factor worldwide contributing to the development of COPD. So, if you have a patient that often smokes, he or she might be at risk of developing a COPD. Now we're moving on to the symptoms of COPD. So, coughing is the most frequent symptom reported by individuals with COPD, but they often seek medical attention when they begin to experience dyspnea. So, as the disease progresses, shortness of breath is more easily triggered by walking or functional activities that involves overhead arm activities such as dressing, grooming, or bathing. So eventually, since they're having a hard time breathing, they're beginning to develop a sedentary lifestyle. And then we have another symptom. So as the COPD progresses, it's characterized by acute exacerbations, including cough, dyspnea, and purulent sputum. And there's the occasion that the patient might have a presence of wheezing. Now we're moving on to the physical examination. So, the physical examination includes auscultation of the lungs of individuals with COPD, and then that reveals a prolonged expiratory phase. So, as we all know, expiratory means breathing out. So, normal in exhalation time is 4 seconds. Anything beyond 4 seconds is indicative of significant obstruction, which can be quantified more precisely by spirometry testing. So we have here breath sounds in COPD are diminished in intensity in all lung fields. So patients with COPD may assume a forward-leaning posture, resting on their elbows or supporting their upper body on extended arms. This position is commonly known as tripoding. So, COPD can be diagnosed by means of using a chest X-ray, CT scan, HRCT, but spirometry is the golden standard when it comes to diagnosing COPD. Now we're on to treatment. So we have here on one box is the medical management, and the other box is for the physical therapy implications. So the goals of medical treatment are to relieve symptoms, prevent disease progression, improve exercise tolerance, and enhance health status, prevent and treat complications, and reduce mortality. So The one thing that's really helpful when it comes to treating COPD is smoke cessation. Smoke cessation means that you have to quit, or a patient have to quit smoking. That's very essential. Next is a pharmacotherapy. This is used to decrease symptoms and to reduce the frequency of exacerbation. So we have here applications for physical therapy treatment like secretion clearance techniques, controlled breathing techniques, ambulation with the use of rolling walker, endurance exercise training, and thoracic stretching exercises. And that's it for the COPD. Let's move on to the CRPD, which is the chronic restrictive pulmonary disease. So, CRPD is a decrease in the total volume of air that the lungs are able to hold. Commonly happens due to a decrease in the LCC of the lungs. It restricts chest wall expansion. So, CRPD happens due to the destruction of the distal lung parenchyma due to the inflammation, toxin, and intrinsic and extrinsic causes. So, intrinsic is everything that is happening inside the lungs, and extrinsic causes are factors that are happening outside the lung. Now we're moving on to the symptoms of CRPD. So symptoms are shortness of breath, especially with exertion, inability to catch their breath or get enough breath or gasping for breath, and long-term cough. And now we're on to the physical exam. Just like with COPD, we start with auscultation, and then when a clinician suspects a patient has a CRPD, they order a PFT, or a pulmonary function test. So this non-invasive test shows how well the lungs are working by measuring the lung volume. And we have here, while the PFT is a huge help, the DLCO is the gold standard for diagnosing CRPD. So DLCO equates to diffusing capacity of the lungs for carbon monoxide. After that, we're moving on to the treatment. So we have here oxygen therapy, lung transplant surgery, and they have medications like mycophenolate, mofetil, rituximab, corticosteroids, and for PT implications, we have breathing conditioning techniques, upper and lower limb shortening, and conditioning exercises. So these are my reference, and thank you for listening.